Great, thank you very much. We are beginning Plenary 0. My name is Dennis Carroll. I'm privileged to be part of the International Organizing Committee and welcome the opportunity on behalf of the Prince Maidal Awards Conference family to welcome you to Plenary 0, which is navigating global demographic transitions in a time of geopolitical disruptions. The timing for the discussion is really significant because it was exactly on the first day of PMAC last year that we got the early signals that the geopolitical governing architecture that we have long embraced was being threatened and potentially underscored. In the last 12 months, events have played themselves out in ways we never could have imagined 12 months ago. A geopolitical architecture that has defined our lives for 80 years is now being disrupted. Not all of that is negative. There's always silver linings. There's always opportunities. But the world we live in today, and as we think about where we're heading over the course of the next several years, we're going to be challenged to think differently, to look at the problems that we know are coming towards us, and create new ways of doing business. In this Plenary 0 session, we will have an opportunity to consider the demographic and health changes which are likely to play themselves out over the coming decades. And we have the opportunity, not just in this plenary, but over the course of the next 2 days in the side meetings, parallel sessions, to consider the challenges of demographic and health, but within the context of the long shadow of the geopolitical disruptions that we are having. I'm reminded 60 years ago, where I come from, we were facing another period of geopolitical disruptions, social upheaval. And the Nobel laureate, Bob Dylan, famously said, as the seas of turbulence were rising, "You better swim or you'll sink like a stone because the times, they are changing." This is a time for us not only to swim, but to swim like Olympians, because the times are changing, and our ability to navigate this process requires us thinking differently and acting differently. The next several days will be an opportunity to meet that challenge and looking at those challenges through the lens of the demographic and health world we are facing. That said, I would like to introduce Chris Murray, who will give our keynote for Plenary Not. Chris is a well-known demographer, and most importantly, he's a man who has been able to take the complexities of the events around our lives and distill them down into manageable, communicable understandings, allowing politicians and leaders to better think about how we go forward. Chris is the founder and director of the Institute of Health Metrics and Evaluation at the University of Washington. He's been a leader in demography and data management and policy thinking. It's really to our fortune as we think about the events over the coming half century and beyond. What is the world we're looking at, and how might we meet it effectively? The opportunity to actually understand the future is an opportunity to manage the future. So with that, I would like to invite Chris Murray As Chris is coming up, the way this session will work, Chris will give his presentation. And then I will invite a number of other colleagues to join us up on the stage and to have a fireside chat. The opportunity to think about the insights and the lessons Chris has talked about and our ability to think about them as a way forward. This is an opportunity to prime, if you will, the pump. The next 2.5 days, you're going to be diving deeply into these issues. So over the next hour and 15 minutes, we'll have a chance to begin laying the table. And I think we heard recently, if you're not sitting at the table, you're on the menu. So with that said, Chris, thank you very much.
Thanks for promoting me to demographer, but I have to be transparent. I'm not a demographer. I love demography. I'm a physician, I'm a health economist, and an amateur demographer. So where are we headed? And that's what I'd like to speak to you about today. And what I want to do is use the global burden of disease, a few words about what it is for those who don't know it, talk about using the data for the last few decades to build models about what the future might hold, and then talk about the implications of those models for demographic patterns, for the burden of disease, and then take a long-term view out to the end of the century in a world where there's a lot of discourse about conflict, pandemics, and nuclear war, as well as climate change, and look more broadly at the big threats that we face. So first, what is the GBD? The GBD, the latest installment published in October of last year in The Lancet, is a systematic scientific effort to essentially measure health around the world in ways that are meant to be comparable, or as comparable as you can get given the patchwork of data. It is disease specific. It also looks at the burden related to 88 risk factors, and it has a large plethora of metrics of disease incidence, prevalence, and rolled up metrics such as healthy life expectancy or disability-adjusted life years. Now, the key thing about the GBD is it is a broad collaborative undertaking. I am sure there's a number of GBD collaborators in the room today. Currently, we have about 19,000 collaborators that are participating in the regular GBD cycle. And this map just shows you where they're distributed around the world, with concentrations of collaborators often in countries where the burden of disease is conducted at a subnational level. For those of you who are going to be interested and don't know the GBD, there's a wealth of online resources. You can get anything that I'm going to show in an online tool called GBD Compare, download the data, get visuals for teaching or other purposes. And there's an online catalog of the 300,000 plus data sources that go into the latest round of the GBD. And it is an ongoing dynamic process. So we're in the throes of trying to finalize GBD 2025 as we speak. Okay, so we have this curated comparable data set that goes back to 1990 for all the diseases and injuries and risk factors. It goes back to 1950 for demography, for death rates, fertility, and for population. So we're going to use the GBD, and we're going to fit statistical models at the cause-specific level, and interestingly, get them to add up to all-cause mortality in a way that yields sensible results. And then we can use those models to think of different scenarios for the future, because of course, nobody in this room knows what the future will be, but what we can do is answer questions like, if the current trajectory of drivers continues, what might the future look like? That's what we call a reference scenario. Or what if we expanded UHC, or what if we did a better job around climate change? How might the future look different? And so there is a large number of future health scenarios, and towards the end of my remarks, I will talk about using this platform to think about long-term threats to human health. Now, for those of you who are more technically inclined, The secret sauce here in the modeling of future health is bringing together three traditions around modeling. We first go back in the past and remove the effect of all the known risk factors. And then we model what's left with sort of models that are driven by economics and education and other broad socioeconomic drivers. And then we have an autoregressive component that's a special type because it relates both to cause-specific and all-cause mortality. And there's lots published and written about it if you're interested in how this all works. The interesting thing is these models actually have pretty good out-of-sample, or out-of-time, I should say, predictive validity. Okay, so we're going to use GBD, models fit to the GBD, and then start running them into the future. But there are some really key drivers of the future that deserve our attention. So first is, and perhaps most importantly, because it's so variable, is economic growth. And the models I'm going to show you that go into the forecast, the reference scenario of GDP per capita, have embedded within them the demographic effects on labor productivity. Namely, we model output per adult, working-aged adult. So if there's a bubble of individuals or the demographic dividend, it's captured. If population amongst the working adults starts to decline, that's also captured. We also have a dynamic model where we move the world forward 1 year at a time so that we can correctly capture the impact of climate on economic growth and economic growth on climate, because they go both directions. And so the only way you can actually do that correctly is to create a dynamic model, which we do. And all of the models that go into this are ensembles of hundreds, if not thousands of models that meet certain criteria. The models also include things like human capital, obviously temperature, and historic rates of growth in each country. Lots of ways to look at economic growth, but I'm going to just show you this slide to start with, which is what is the ratio of income per capita in the US compared to the US as a benchmark in 2100 by country. And the purpose of this slide is to say in this reference scenario, doesn't mean it's what will happen, but it is what current trajectories would suggest, we will still have a world at the end of the century with enormous economic disparities. The countries in red would have an income per capita less than 5% of the US in 2100. So given demography, given climate change, given the trajectory of economic growth, we still will have enormous economic disparities end of century. Doesn't mean it'll happen. If we ran these models back in 1950, Asia would have looked very poor. So it can obviously change, but we need to change the course of this if we want to have a substantial effect on health. What about extreme poverty? So if we take the UN's definition of extreme poverty with inflation, that's now $3 a day. The good news is on the left panel, left of the vertical line is the rates of extreme poverty. They have been declining dramatically at the global level, a little bit less dramatic in sub-Saharan Africa in purple. But right of the dashed line, even though we expect poverty rates to continue to decline, unfortunately, they're not going to decline fast enough in the reference scenario to defeat population growth. So the numbers of individuals in extreme poverty are actually expected in sub-Saharan Africa to grow, not the rates, the numbers. And so we still have this large number, 750, 800 million people in extreme poverty well into late century that will have profound health needs and affect health outcomes to a large extent. So this is a good example of the interplay of economic growth and population growth. And what some of those familiar with the sort of teachings, a pretty classic example, I'll show more of them, of what's called Simpson's paradox, where at the global level, things are getting worse, even though in every single region, things are getting better. And this happens in health quite a bit. What about schooling? Well, we can start with where we are now in 2023, We now estimate survey sources on schooling because it's so important for health outcomes at the district level. So this is a map of average years of schooling for both sexes combined in adults at the district level in the world in 2023. And we can use this information on the spatially resolved level of education to run models into the future. When we do that, it turns out there's an interesting disconnect that we expect, it's been happening already, between economic growth and advances in educational attainment. So if you look at somewhere like sub-Saharan Africa, economic growth has been quite slow on average, less than 1% per capita over the last 40 years, whereas education expansion has been really quite profound in the red line. And so we expect some disparities in education going into the future, but you will have a world of much more educated people that have not yet reaped the benefits of economic growth in this sort of reference scenario, with lots of implication for migration, as we'll talk about at the end. What about health spending? Well, we can also take GDP per capita. We know there's some very strong relationships between GDP per capita and percent of GDP spent in public and private sectors on health, and run this scenario into the future. And what we find out is that there will still be, right to the end of the century, countries spending less than $100 per capita. So as we live in a world of scarcer resources for health in the short run, that scarcity may continue well into the century, with the implication about how important it is to get more health for the money, unless you can basically profoundly change the trajectory of economic growth in sub-Saharan Africa. What about development assistance for health? Well, here's one of many, many scenarios that might occur. This is our reference scenario. And it's sort of an optimistic one if you think about where the global discourse on development assistance has been. We've seen the big cuts. We expect, because of economic growth in some countries that continue giving, that'll go up. When the Gates Foundation exits the scene, we'll have that notch drop in development assistance for health. And then maybe, if we're lucky, it continues to grow, and maybe out to the end of the century, we're still in the $40, $50 billion range. Of course, that may not play out, or it could be much more positive, because this is truly a policy variable that can be dialed up or down depending on the politics of development assistance. Okay, on to talking about fertility, migration, and population. So in our models at the Institute for Health Metrics and Evaluation, and we've published these since 2017, I believe, we have a model that takes into account not just fitting time trends to past data, but takes into account education, the child death rate, urbanization, as well as access to modern contraceptives. And when you combine those and run those models into the future, we see sustained fertility reductions that don't bounce back in middle and high-income countries. And we see slow but steady declines in sub-Saharan Africa. And what this translates into, shown here, two ways of thinking about it. The gray line are countries below replacement, below 2.1 children per woman. And we expect the number of countries below replacement fertility just to steadily keep rising, as you might expect, given the past 75 years. And then about 30 years later, if you think about it, because of demographic momentum, after you drop below replacement, about a generation or a generation and a half later, you get the natural rate of increase going negative. In other words, your population will decline unless you bring in migrants. And so that's sort of baked into the demography here. And of course, the control variable here that is very much in the hands of government is whether or not migrants are welcome in different countries. And we'll see that that will matter a lot. What does this mean for global population? Well, on the left, in the green line, is our most recent assessment. We published about 6 years ago, global population peaking in 2063. We're now about a year later, not much different. So we're sort of following the models as we had them 6, 7 years ago. No real surprises in the current trends. I mean, Chile has been a surprise for us, dropping to below 1.1 rather abruptly. So that's been a bit of a surprise. But basically, globally, the world's population should peak around early 2060s at about 8.5 billion or now, and 9.5 billion at the peak, and then start to decline. Now, what happens in sub-Saharan Africa to economic growth and education has a huge influence on this. So you can move this curve up and down based on what happens, particularly to education for women in sub-Saharan Africa. But in the reference scenario shown here, look at the share of global population at the end of the century in red in sub-Saharan Africa. We will be moving to a world where almost 4 out of 10 people will live in sub-Saharan Africa. So a huge shift. This is a shift towards the places that currently are the poorest, with some exceptions. This is a shift to the places where the effects of climate change are the largest, particularly in the Sahel. And this is a shift to the places where child mortality is the highest, with a few exceptions. So we have this demographic pressure towards outcomes at the global scale that make it harder and harder to make global progress, even if many of countries are making progress. What does this do to population pyramids? Well, very big if the US maintains its historic pattern of bringing in migrants, which of course, if you saw the Census Bureau data today or yesterday afternoon, we're down a lot, but still bringing in some migrants. But if that historic pattern continues, then you get a country that doesn't go down very much, and it ages somewhat, but not profoundly. So blue is what it is today in terms of a population pyramid. Red is mid-century or peak population for the world. Black is the end of the century. Contrast that to China, where population has been declining for 4 years running, and there's no suggestion this will stop. And so we expect enormous population reduction over the century, particularly or more profoundly in working-aged adults than in other age groups. And you can see this extraordinary population pyramid of going from blue to red to black if the trends in the total fertility rate continue and China doesn't bring in migrants, which historically it has done very few. Nigeria, in contrast, is still in the growth cycle. And you see that Nigerian population might reach a peak of 680 million, would surpass China at the end of the century. And really what's mostly happening in Nigeria is mostly maintaining the size of the birth cohort, slightly larger, but it's just aging through, as you can see, the black diagram compared to red as you go forward. Now, I can't show you that for every country, but this map can show you the change in population expected on this reference scenario for each country from 2025 to 2100. All the places in red are having really profound population declines in the 60 to 90% range. And then on through the browns and the yellows, population declines expected. And then the countries in blue, either because of the total fertility rate remaining high, Niger, Chad, as an example, Somalia, or because they continue bringing in migrants, Canada, Australia, New Zealand, as examples. So enormous differentiation globally in whether your population is declining or your population is increasing. And then the really big question is what actually happens to migration, because we just don't know, because it's so much a policy control variable for countries to either welcome or not welcome migrants. What does this mean on these trajectories for future health? Well, the good news is despite obesity, despite climate change, despite continued pandemics, we expect global life expectancy and regional life expectancy to continue to grow, which is great, despite all the threats that are out there. But we also expect that disparities will continue, and that's going back to that economic growth that we saw for sub-Saharan Africa. Here's the burden of disease in one of our traditional tree maps that you can get in GBD Compare, where the non-communicable causes are blue, injuries are green, and the communicable maternal and neonatal causes are in red. And what's interesting about this tree map out in 2100 is just the enormous burden of diabetes, fueled by the obesity epidemic, shrinking burden of ischemic heart disease and stroke, but still present, lots and lots of musculoskeletal disorders as people age in the top left, lots of Alzheimer's in the middle blue boxes, plenty of cancers, plenty of mental health disorders, depression, anxiety particularly stand out. But despite 75 years into the future, guessing what might happen, these models suggest still quite a lot of burden, particularly in low-resource settings, from TB, from malaria, from pneumonia, from neonatal disorders. And of course, falls, road injuries, and suicide are prominent on this cause list as well. What about risk factors? Well, we can run our risk factor models into the future and ask the hypothetical question, if these models ran true, what might be the burden of the big risks as we go into the next 75 years? And at the top is high blood sugar and obesity. They're very linked. Then high blood pressure and diet. Air pollution next, tobacco. Then we still have malnutrition, high temperature, high alcohol use, and occupation, and on down the list. So a risk factor profile in the future with a huge role for obesity, blood sugar, blood pressure, diet, air pollution. Now, what are the opportunities to change the trajectory in the future? And I want to tell you about an initiative that started 3 years ago, which is the Lancet Commission on 21st Century Global Threats to Health. Ongoing, should be submitting and finalizing its final report in the next few weeks, and hopefully published in the next few months. And this is a group both of health experts, political leaders, global health leaders, co-chaired by Natalia Kanem and myself, with a diversity of regional viewpoints, people from parliamentary, Martin Chungong, for example, the Secretary General of the Inter-Parliamentary Union, specific expertise leaders like Dame Sally Davies on AMR, climate leaders like Trevor Hauser, and others. And here's some more members. Mario Monti was our only former head of government, but very active on the commission, trying to bring that political lens to thinking about threats. So we started with what I showed you, the forecast of the reference scenario into the future. And if you count up all the diseases and all the risk factors, there's about 500 on that list. And from the 500 on the list, we added some things like nuclear war, AI, and then we boiled down to the biggest, the threats that, or the problems and threats that were likely to cause at least 1 billion years of healthy life lost. To put that in context, COVID was about 500 million. So 2 COVID epidemics, if you want to think about that as the threshold. For these 17, we wanted to figure out how much of each of those threats was amenable to action. And we wanted to ground the notion of amenability in observed data in the past. So this is not amenable if we have some dramatic technological breakthrough, but if some countries have held the increase in obesity to a low level, well, that should be achievable. If some countries have done a really bad job, well, that's also possible on the plausible worst front. So we both ground the level of a threat on the observed data of the past 40 years, but we also, to make plausible scenarios, we say that the rate of change to get to that scenario is also bounded by past rates of change, or what we call velocity. Now, when we do that, we come up with this somewhat surprising to us all on the Commission evaluation of the 17 threats. We started assuming that pandemics, war, and climate would be the absolute top of our list. They're certainly amongst the major threats. But it turned out that in terms of this notion of what's amenable to action in the future, obesity is number one. Then low education, number two. Continued income inequality, number three. Then tobacco, then unhealthy aging. But in the discussion around the magnitude of what's amenable, we realize there's another dimension, which is, are some of these threats, like malicious AI, even if we don't expect it to be the largest, using sort of the expected value, probability of outcome, harm of the outcome, but there's an extinction risk. And so we came up with a tier one set of threats, which were the three biggest: obesity, income inequality, and low education. And then the two threats that we viewed had an extinction risk between now and the end of the century. Malicious AI, including the design of bioterrorist weapons using AI, and nuclear war with, which is quite controversial, nuclear famine. The literature's gone in both directions as to whether you can get extinction from nuclear war, but currently I think the consensus has moved back to that is a real risk. And so these are our top tier threats on the Commission. And then tier two threats are the ones that are really big. They all meet our threshold of at least 2 COVID epidemics, but there are a longer list of these threats shown here: climate change, air pollution, pandemics, AMR, and as you can see on down the list, including, for example, conventional war. So leaders in health systems and governments can't just focus on pandemics, climate, and conflict. They really need to plan for and think about a much larger set of threats that society faces, and every threat is essentially an opportunity for action. So we end up with 3 recommendations in our commission. Science keeps changing. We've been asked, what about mirror life? And we don't include that in our assessment. We didn't think there was enough evidence yet about the threat of mirror life. But we believe that you need to pretty regularly evaluate what are the big threats for society. Some threats require new innovation to see better progress. So increasing investment in innovation to address some threats, we believe, is critical. And then perhaps the most important one for us as a group was the idea that health systems need to invest in being threat ready, not just pandemic preparedness, but dedicated resources to planning for and managing a much broader set of risks for society. Let's zoom out and close. What are the really big issues if you care about health, as we all do in this meeting? Probably the biggest is what can be done, not that we in health can do a lot, but we can advocate for, to address slow economic growth in many parts of sub-Saharan Africa. And that's its own direction. There's obviously a role for human capital formation, but there are other governance issues and investments that may help. Number 2, as we're seeing around the world, there's going to be a profound push-pull phenomenon on migration. There's going to be more and more people in the very regions hardest hit by climate change and low economic growth, in the Sahel particularly. And there's going to be real need for workers in many countries if they're willing to welcome migrants. And there's going to be a political backlash because of that dynamic in many countries, as we're seeing. So understanding where people will have to leave, because that becomes unlivable, where they might go, how you might manage that becomes an incredibly important issue, and one that the health sector has largely decided it's somebody else's business to worry about. Third, obesity is the biggest threat we face in terms of health, and there's a lot of things that can be done to address it, and we really need to grapple with it. Fourth, AI, lots of potential, but enormous risk. I don't know if any of you have read Dario Amadei's essay that he published 2 or 3 days ago, the 20,000-word essay on all the ways that AI might really lead to bad outcomes for society. Of course, he's joining many others who are sounding the alarm on the need for regulation on AI. And then lastly, that demographic trend, the slow economic growth, low spending in many parts of the world means we really need much more emphasis on how to get more health for the money in the future than we've had in a period of sort of the golden age of global health, where resources, at least up to the just after COVID, kept going up and up. And now we're in a phase where that's unlikely to be the case. So there are some real opportunities that these analyses suggest. Reducing income inequality is a surefire winner, as from the data that we can see. This is not a political statement, it is just an empirical statement. Accelerating educational attainment and tackling obesity can all have enormous health effects. Making health systems more effective, expanding UHC, and understanding how to build threat-ready health systems, we believe, hold out enormous opportunities for the future. Lastly, let me end with 3 questions for our esteemed panel coming, because I was asked to, which is, given the impact of demographic change and the wide range of threats ahead, how do we prioritize action in such a complex, diverse world that we face? How do we learn from each other about system performance and getting more health from the money, for the money that's available? And how do we build threat-ready health systems? Thank you very much for your attention.
Thank you very much for really setting up our pending discussion. Well done. I'd like to invite our panelists to come up, and I will, as you're coming up, I'll just provide a brief bio. There are more extensive bios in the PMAC website, so I would ask you to go. Gabriel Leung, he is the director of the Institute of Philanthropy. He is also the executive director of the Hong Kong Jockey Club, overseeing its charities and trusts while serving as a governor of the Wellcome Trust. Keizu Takemi, he is the former Minister of Health, Labor, and Welfare for Japan. Currently, he is a senior fellow of Japan Center for In Exchange and has been serving as chair of CCIE's Executive Committee on Global Health and Human Security. Precious Matseso, she is the Director of Health Regulatory Science Platform with Health Consortium, South Africa. She's also the former Director General of South Africa's National Department of Health. And Magda Robalo, she is the co-chair of UNHC 2030 and is the president and co-founder of the Institute of Global Health and Development. And if we could leave those 3 questions. As we're preparing, I would like to start just by asking the panelists just to take a moment, a couple of minutes, just to reflect on what Chris just said, and if there are things that particularly struck you that deserve much more consideration. Magda, could you go first?
Yes, thank you. I think from what I heard from Chris, and congratulations to the Commission for an excellent report, is the number of threats that we actually face globally, not only in terms of what comes from the health sector, but holistically, globally, all the threats that affect population, demographics, and compromises our ability to even have major or more impact within the health sector. The intersection between population, economic growth, migration, climate change, inequalities, etc., is something that makes us think about our approach to redesign the global health governance and architecture that we are currently doing. I think we remain too focused on the health systems, and I liked one of the recommendations: the health systems need to be threat ready, not just pandemic ready. And that's a very strong message for all of us. So,
thank you. Precious?
Yes, thank you so much, and congratulations for the Commission report. In fact, what stands out for me is the African picture. And it's worrisome somehow, in that I see two things on the population side. The first is the youth bulge on one hand, but also increasing life expectancy and a possible aging population. So these are twin problems that we'll have to deal with. And I think the most disturbing thing is that unemployment in the region is double digit. But we also heard about opportunities. In fact, I was thinking that the earlier keynote address about the informal sector in the region is an opportunity, and maybe we can, based on the discussions, learn from how the Asian region converted the informal sector towards improving to GDP growth and also GDP per capita. Maybe this is where our solution could be, I don't know. The second is about the burden of disease. Obviously, the key drivers would require regulatory interventions. The question is there political will? I mean, political will to deal with social determinants of health? Is there political will to address the key areas where there are risk factors, for instance, for obesity, for nutrition-related, dietary nutrition-related areas, where regulation in some areas has shown to work, like introduction of taxes and so on. So it will be good to see whether, can we learn from those areas. And the last one, and I was also struck by the education level, and again, our region also shows, even though there are exceptions and outliers, it still requires that there should be investments in education, because education is still one of the most potent tools that can help us fight poverty and make changes and lasting changes. Of course, others as to security. In fact, I had a question for Chris, if I may, about why you categorized, you separated conventional war and nuclear war. To me, war is war. Nuclear or not. Anyway, we'll probably hear as to how we deal with war, because we really need lasting peace. There can never be peace without justice, and there can never be justice without peace. We need both, and maybe we can talk about how do we achieve that. So I'll stop there.
Thank you. Keza.
Okay. My impression from the Chris's wonderful presentation, from my own viewpoint, I myself, as a political practitioner, up to the last year, I was a parliamentarian, works for the politics. And then we are talking those demographic change and the geopolitical conflicts. And then how the geographical conflicts will impact on those health issues. Maybe we have to analyze in much more detail. And then sometimes those outcomes can be, unfortunately, much more negative. And then also I have to say that in a global context, in the politics, as a result of the US withdrawal from the WHO, this was a trigger. But now that many conflicts happened in so many places, and ordinary people pay much attention on the national security rather than the health security. And then, as a result of those political tendencies, now we are having large size of the global diplomatic vacuums. How we can fill up those vacuums? That's the reason why now we are started to talk about the global health governance architecture. That sort of discussions need the political wisdom. The political wisdom is not only for politicians in the public sector. Now we need the political wisdom of the private sector and the civil society. And then how we can fill up those the new unfortunate the political vacuums in the global health can be recreated and then designed the sustainable global health governance architecture. And in addition to that, the finance should be given the first priority because of the control knob for the health system strengthening. That the universal health coverage, when we talk about, we always simultaneously have to think the UHC finance. That's the reason why the Japanese government proposed to launch the UHC Knowledge Hub focusing on the health financing. That sort of challenge are now starting so many places, but how we can combine those, the different the challenges into the more efficient umbrella. This is the challenge of the political wisdom. Thank you.
Gabriel.
Thanks, Dennis. You asked what has struck me in particular after hearing Chris's talk. I've always been a card-carrying fan of Chris Club. I actually even carry his tome. 90% of his talk was based on this report, published a few months ago last year, about GBD 2023. It happens also that 500 years ago, almost to the day of the publication of this in The Lancet, was a guy named Albrecht Dürer. If you call him the first person, first individual, or first father of measurement, who essentially gave allowance for and facilitated physical architecture. Because without Dürer's work in measurement, and precise measurement, there would have been no modern architecture, or even medieval architecture, for that matter. If you then think 500 years later, this, to me, is the equivalent of that book that Dürer published called Teaching of Measurement. Because picking up on what Keizo Sensei just said, we are now facing a critical turning point in reforming and redesigning the global health governance architecture. That architecture is no less consequential than physical buildings. And to me, you do need learning, you need evidence, and that is what Chris and the IHME have brought to us in the past couple of decades. Yet, we were reminded, as we have been every year at the very beginning of PMAC, of the philosophy of Prince Mahidol. And again, let me just quote. He said, "The success is not in the learning, but in its application to the benefit of humankind," which goes to your very first question, Dennis, that is projected on the screen. So how do we actually use the learning that Chris and colleagues have produced to get to a better global health governance architecture? And perhaps just one thing that I should like to say at this point is, we've come at it from a health practitioner or health worker-centric perspective. But no matter how well we do or how influential we become, it's actually not the most powerful sector in any economy that I know of. And therefore, perhaps we need to study power structures, power dynamics, and make it, like it or not, a power-centric approach, so that who says or who gives the evidence and who owns the evidence, actually we flip it the other way around, so that ultimately is the powerful deliberators and politicians who ultimately would end up redesigning and redefining the global health governance architecture. With that, I give you back the time.
Well, let's continue on this strain of thought. Chris, how would you react to that?
To which? A lot of...
To Gabriel's point.
You know, I think there's a lot we can learn from, you know, political science and other groups that try to study this in some way. That said, I think one of the groups that we probably need to reach on the sort of health front is the national security community, because they have more power. And in theory, they say they're interested in threats. They just have a very specific threats around bombs and guns and spooks and things like that. But I think there's, you know, the pandemics have entered their mindset, but there's no reason we can't broaden or try to broaden their sense of threats. And Mario Monti, who was on our commission, was very articulate about that. We really need to more routinely reach with the dialogue, ministers of finance, you know, heads of government, and maybe use that angle around national security. It's one strategy. I don't pretend it's the only one, but it is one that we'd like to pursue. We're going to actually have a session at the Munich Security Conference on some of these findings for that reason, trying to get a different community to listen.
Yeah. Chris, I think you'll remember in 1999, the National Security Council at the US, in fact, flagged HIV as a national security issue. And that set the stage for PEPFAR. So it is an example how leveraging, because they didn't see HIV simply as a health issue. They saw it as a social disruptor, an economic disruptor. And as a consequence, it elevated itself to a priority agenda within the United States government. So, you know, there's clear examples of that sort of national security issue driving a health agenda, but driven by much broader collateral consequences with respect to that health issue. So we have a good example of that. Yes?
Yeah.
Yeah. Precious, what would you say about, you know, as we think about this first question, you know?
Well, I think, I mean, the health has also been described with a security lens, health security. And you'll recall that the movement that the US started on the health security agenda was not just, it was not driven by the security apparatus. It was led by State Department and coordinated with various sectors. And we've seen that happen in different countries. And if you look at the health security agenda and you look at all the work packages, they actually involved different sectors: agriculture, health, defense, finance, and so on. And I guess you probably need, perhaps at the head of state level, the coordination of different sectors to respond to all these. But there are two things I wanted to flag. One is to Chris. Yes, you've produced the GBD, but you still need data, you still need information at country level, at national level. And one of the missing pieces is the demographic health surveys. These are not done. And perhaps if there can be advocacy for that, because it's key. Yes, this gives us a global picture, but we also need to see a national picture for countries to respond. What kind of ways can we push for demographic health surveys to be conducted at national level?
The second question, how can we learn from each other? One of the sort of striking points within your presentation, Chris, was the tracks that Asia demographically are on and the tracks that Africa are on. If you had gone back in time and showed Asia 1980, 1990s, in many ways it would look similar to what you're projecting for a bulge in sort of the workforce and the rise in non-communicable diseases and the challenges that the health system faced and being able to manage that transition. I'm thinking about lessons learned and insights gained. I'm wondering, Kejo, from your experience, what is it that Asian countries grappled with 30 years ago as that demographic transition was presenting itself in Asia that may be of relevance to Africa as it begins to grapple with such a challenge as well?
When Japan introduced the elderly care insurance system in 2000, the rate of the aging was only 12%. Now it's nearly 30%. And the other Asian countries, the speed of aging is so speedy, much speedier than Japan's speed of aging. Sometimes they have to handle large size of the elderly population without any preparation for handling the elderly population. For example, how to finance those elderly care services, and also how to prepare for those the really qualified the health labor forces for elderly persons. Not only the medical doctor and nurse, many other paramedicals, the workers should be required. Madam Chan just mentions in the wonderful remarks before the meeting. Therefore, how the government previously take the initiative to prepare how to cope with the future increasing elderly population, and then define the public status of the paramedical care workers as fast as they can, and then build up some schools, and then started to produce those qualified elderly care workers in various purposes. And then you can introduce those universal elderly care insurances and give those of the elderly persons can be affordable to receive the qualified elderly care services. That sort of a preparation and the collaboration should be required. Japan is the most advanced nations. Now 82 medical doctors and 82 medical schools in Japan. But the elderly population is now declining, and also the total population is declining. We don't have to have such a large size of the 82 medical schools anymore. And also caregiver schools are now 40% of the students come from abroad. That sort of things happen. Therefore, we can prepare to receive those falling potential caregivers and also paramedical students to the Japanese educational system and assist to produce those elderly care workers in the future. That sort of collaboration beyond the national boundaries can be invite win-win game in these circumstances.
Chris, in your presentation, Africa really stood out for me that by the mid-century, we're going to be looking at a threefold threat. They're going to be grappling with increased geriatric needs. They're going to be grappling with sort of non-communicable diseases and the bulge of a middle-aged young workforce. But you're still going to be grappling, based on the data that you showed, you're going to still be grappling with communicable diseases. This very last question about a threat-ready system. How do you build a threat-ready system that meets what are triple threats, above and beyond the ones that you presented to your penultimate slide, right? Magda.
Thank you. Janice, I think just to pick up on what Professor Takimi said, I think we are coming as the African continent from a very different place where Japan was facing the challenge they had. They were more social and economic developed than we find ourselves today. And the huge number of young people that we have today don't have the skills probably Japan had with the 82 schools of medicine. We don't have enough schools to train the people that we will need for the jobs of the future. So preparing health systems for a complex range of threats is going to be a major challenge. And that takes me back to the first question to say we need, in order to prepare health leaders to prioritize action, we need to make sure that they have access to information, not in an asymmetric way. Of course, the national conditions differ, and each one will make use of the information depending on their context. But I think this is information that needs to be widely made available so that, be it in Africa or in America, wherever in Asia, leaders can be cognizant of the wide range of threats they are facing and sit down to design health systems for the future or even for the present that take into account some of these major threats. Obesity is on top of one of the threats we have seen. And with actions today, we can curb the trend in the next 10, 20 to 30 years and avoid epidemics that we are seeing in other parts of the world. So I think it's looking back of what other countries have gone through that we can start learning lessons and preparing for health systems that are future-proof, but also being cognizant of the challenges we have. Continued slow economic growth, as we have heard, continued increase in fertility rates, which are quite different from the challenges in other places, and we need to come up with unique solutions to fit our context while learning from examples from other parts of the world. Thank you.
I'd like to open this up. We have maybe 10 more minutes, and I'd like to open it up to questions from the audience. If when you come up, you could identify who you are, and then keep your questions very much briefly. Over here on the left.
Thank you. My name is Tawfiq Jawardar. I'm originally from Bangladesh and currently working at Singh Health Duke NUS Global Health Institute in Singapore. My question is, we realized that the elderly population actually increased quite rapidly in Southeast Asian countries and East Asian countries. But that was kind of, at the same time, we experienced a good economic development, economic growth as well. But my question is more about South Asian countries, which doesn't have that level of economic growth. So do you, as demographers or public health professionals or epidemiologists, anticipate a similar type of growth in elderly population in those countries, and if so, with not so a good economic growth, how these countries should really react to this and how should they prepare? Thank you.
Gabriel or Chris, would you like to tackle that?
I think that it really goes back to the third question. Spot on question about South Asia, ASEAN, or East Asia. To me, I think fundamentally is how would we pay for it? The demographics, the population pyramids are scary because still the predominant way of prepayment for health remains pay-as-you-go. But that is predicated on a population pyramid that actually looks like a pyramid. None of the figures that Chris showed look remotely like a pyramid. And so that's one, and that's the static picture. The dynamic picture is even scarier because they all become very skinny. And when you shrink your population and invert the shape of those pyramids, that's a double whammy. And I don't think anybody has figured out a politically acceptable way of risk pooling to pay for threat-ready health systems or social welfare systems quite yet. And that, to me, I think is the crux of the matter, because if you still remember the theme of this conference, there is that word equity in there, equity approach. And to me, there is nothing quite so toxic and so vexed as the whole issue with disparities, which is the other way of putting equity, because to me, it ultimately drives populism, nativism, or even tribalism within countries. And therefore, the demographic forces are going to intersect with these corollaries of disparities. And if you've got all of those together, it's even harder to come up with a new and different way of paying for all of this. And that is why, let me just conclude by coming back and looking forward to the difference the WHO, World Bank, Government of Japan, UHC hub is going to do. I have really gone to a lot of these meetings and inaugural events for a living in the last 2-3 decades. But the recent inauguration, where you actually get the finance minister and the health minister on the same stage, tells me that there is hope yet. And so getting the payment right so that we can actually effect threat-ready health systems, to me, would be a huge step forward.
Thank you. We go over here.
Good morning, everyone. I'm Jeff Acaba from APCASO. We are a regional civil society network organization based in Bangkok and Thailand, and we work in 17 countries in the region. I have a comment that will lead into a question. I do appreciate that we are framing health issues from the perspective of threat and global health security, but we learned from COVID, even from way back to HIV, that when we frame a particular health issue as a security threat, not only that it exclusively pushes away communities and populations who are at risk and key and vulnerable populations from participating, but they are the ones who fall within the cracks. We learned from it from COVID. It's the communities who have eventually fended and helped themselves because the governments do not listen to the communities. That having said, I'd like to pick up on what Precious said earlier about the issue of justice. And how do we then frame, as we prepare to reimagine the global health structure, architecture, that our components and the systems that are in place are responsive to health injustice issues? For example, issues of access, addressing harmful gender norms, stigma and discrimination. One of the things I saw in the presentation is that the malicious use of AI is a threat. But then when we come to think about it, what's the health outcome that it wants to particularly pertain on? Because if we ask ourselves, in the people in this room, one of the reasons why we access AI is because of our mental health issues. And the reason why we do that, and I don't know how many people in the room actually use AI to ask them about mental health issues, is the lack of access to mental health counseling, because it's not normalized. So how do we then prepare global health architecture to become more responsive to health injustice issues, rather than forcibly forcing ourselves to face a particular threat when the roots is already there?
If you could pause
Thanks.
there, we have limited time. Precious, if you could respond.
Well, I think firstly you're right. I mean about access and justice, but on the AI, I think we need to be cautiously optimistic. In that, on one hand, of course, there are embedded risks, but there are also benefits. And in that regard, we probably need to bring some ethical dimensions to it and be able to put in some regulatory frameworks that are balanced and nuanced. Firstly, not over-regulate, because that kills innovation, and at the same time not under-regulate, because it poses risks. So the question is, how do we come up with an effective regulation that is appropriate? And how do we ensure that government does, creates an enabling environment that makes sure that people access digital tools? Because at the moment, it's an access problem, and in particular in the African region. So it's access to digital tools, but appropriate and effective regulation.
Great, thank you. We're going to only have time for one more question. My apologies, but time, we have another plenary happening right after this. So if we could go in the middle.
Thank you. Fantastic discussions, and thank you, Chris, I'm a big fan of your work. I'm Tav from IIIT Delhi. I'm a data scientist and a public health practitioner. So my question is coming from that standpoint of data science. You brought up malicious AI as well as AMR, both of which are, and of course, obesity and other diseases as well, which are hugely influenced by behaviors. How do we think about bringing in the behavior component into the modeling that you do? So what's a modeler's take on that?
Magda, do you want to try that? Should it?
I completely agree. I mean, many of the things on the list, alcohol, tobacco, obesity, behavioral change is at the core. The difference between what we observe across countries, there has to be a behavioral element to it. And I think if we want to, achieve what we think is amenable by looking across different communities, the answer is going to be definitely on the what are the drivers of behavioral change. So I couldn't agree more.
Thank you.
Okay, if I could just ask for just a quick, Kezo, please.
No, this session is very important. I do realize that now the health financing is under emergency. And then how we can handle this very serious health financing emergency is one of the key part of the global health governance architecture. And then we are now under the very serious geopolitical conflicts, and large size of the diplomatic vacuums exist. In this room we are gathering, and we have to think how to fill up those vacuums and recreate those real functionable, the governance structure for the global health is a part of the urgent issue for the health financing. The presentation give us the wonderful impressions, which give us that to how and which should be given a priority for these subjects. Therefore, I really, appreciate that when Japan was the host of the UHC Knowledge Hub for health financing, WHO and World Bank closely collaborate each other, and also national levels that the Ministry of Health and Ministry of Finance closely collaborate each other to be the host. and the purpose is to widen the fiscal space of the low and middle income countries. This means that respect the ownership of the sovereign nation. Now we have to rethink the role of the sovereign nation and the ownership of the sovereign nation, and don't rely on the global assistance anymore like in the past. The golden age of the global health has already gone. Now, once again, from the fundamental position, we have to rethink how to restructure the global health societies. The Chris gave us the wonderful health mapping, under which we can get the joint together and then think about the whole picture as fast as I can. Thank you for PMAC give us this wonderful occasion to talk about it.
I think what we've just heard is a call to action for the next couple of days. I think the question and the challenge Keizo just presented is an opportunity for us in the various parallel sessions to begin taking a deeper dive and trying to come to a final solution on that. So we're going to have to end. My apologies. I know you can grab people as they're following this, but we need to end because Plenary 1 is following on. So to each of you, thank you very much. Really appreciate it. Chris, thank you for really kicking us off in a great direction. Greatly appreciate it.